Okay, the next category I want to go in is the pediatric KAFO for treatment, and just I changed this terminology from blounce because it's not specifically for blounce. It actually treats any bowing deformity, whether it be valvum or barum of the lower extremity. So we've changed the name to pediatric system. I'm going to talk about different variations in bowing. Time flies when you have fun, doesn't it? Evaluation and management, orthoses and design review, case studies and design variations, and then summarize it. I'm going to look at normal alignment because I think it's important. We all appreciate that. Physiological, bowing, blounce disease, and rickets specifically today. When you look at normal, as far as the anatomy itself, this is the physis, so the growth plate right here. In the kiddos, this is the epiphysis. These are all the common terms that if you're dealing with these patient populations you need to be aware of. And the diaphysis is the long bone. And this is the metaphysis, this triangular shaped area between the diaphysis and the epiphysis. When we look at the normal developmental aspects of tibial femoral angle during growth, over here you have varus, valgus, the ages across here. You can see it's 2 years old. Up here we're starting about 16, 17 degrees of varus when the child's to be born, and then as the child ages and gets down to around 2 years, they're neutral. Maybe just a slight varus there, and then as they age further, get out past 2 into 3, you're actually seeing some valgus deformity occur in these patient populations. This is normal. It's important to understand this so that you can determine whether or not the patient, this would be the first marker if the patient's 2 years old and they still have 15 degrees of genu varum, or they have 15 degrees of genu valvum. That may be a consideration. These patients see an pediatric specialist, get some x-rays, or at least get a baseline exam to find out if there's anything going on. They need some type of intervention orthotically. To summarize that, maximum varus at 6 to 12 months of age is about 15 degrees, okay? And they should start to be neutralizing after that up to about 2 years of age. You want to start seeing things change dramatically between this 6-month period here. Maximum volume at 4 years of age is about 8 degrees, so it's normal to have that. And by 11, things have stabilized, and they usually end up with about 6 degrees of valgus as a general rule as part of the deformity. When you look at physiological varum, there's an exaggerated varus angle during the 2nd year of life. So if they're 2 years of age and there's excessive bowing, it's physiologic typically. It's also centered at the knee, meaning it's not tibia vera or blounce where the tibia is just bowing and the feet are straight. There's no actual valgus deformity. With physiological varum, there's actually a varum deformity as well. Early walking typically leads to physiological varum. Overweight also is a factor in that. African American also plays a factor. Radiographically, the tibial femoral angle of at least 10 degrees is classified as being physiologic. They have a normal period growth plate. We'll talk about that in a little bit. And then often the distal femur is involved as well. There's a little bit of involvement there to get that true varum. Center rotations at the knee, not distal to the knee. And then these are the measurement classifications in regards to the age of the patient, regards to specifically physiological bowing. And then the metaphyseal diaphyseal angle, that's the primary angle that the orthopedic surgeon will look at to determine whether or not it's blounce or not. And these are the averages here in the range of that deformity. Here's a physiological patient here at 16 months old. You can see the significant, what's happening here? Just not the patient. How much varum deformity at 16 months at 43 degrees, that's significant. It's way beyond normal, so this would be a child that had to be watched. You can see as he aged, got up around 23 months, you can see the angle reduced to 23 degrees. But he's 23 months old, he still needs to be watched. There's orthopedic surgeons, orthopedic surgeon, pediatric chief at Cleveland Clinic. His philosophy is at 2 years of age, kids put their feet together and their knees aren't touching, he's going to brace them. That's his philosophy. That's pretty aggressive. But he's also thinking, he says, Joe, what do you got to lose? He says, you don't brace these kids and they do get worse. Later on in life, they're going to have these huge bone deformities, OA, severe OA, all these major problems and everything. If you do brace them, there's a good chance that you're going to correct them. Number one. Number two, if you do correct them, the long-term results are not great. Most of these kids end up with from 2 to 4 surgeries over their surgical lifetime when they're between 4 and 8 years old. When we look at Blount's disease, it was originally identified by Erlacher in 1922, and then Blount described it in 1937. And he was at the Children's Hospital in Milwaukee, Wisconsin. When you see these Blount's patients, typically bilateral, the percentage is 60 to 70%. More prevalent in female, common in African American. Overweight, this is becoming even a bigger concern. This is a huge market, I think, now because of the obesity concerns with kids and stuff. I mentioned to you earlier, we had a 3-year-old at 100 pounds. There's a direct correlation between obesity and Blount's disease in these kids, adolescent Blount. Walking at an early age obviously contributes to, there's about a 40% increase if you have a family history of the child going to have Blount's. When you look at the etiology of pathogenesis from a mechanical standpoint, again, walking at an early age, overweight, loading the extremity, the Hooter-Volkmann principle basically is a pressure principle where there's too much pressure on the medial compartment and actually inhibits the chondrocyte growth on the medial compartment. That's some of the philosophy behind what causes Blount's disease. And it actually delays the ossification of the actual epiphysis. That's where you get that lipping effect on the medial side. And then there's some unknown etiology. It could be genetically related, some blood-borne concerns, possibly the biomechanical, obviously alignment issues. I mean, that's what this is all about. You have something that's abnormally aligned, whether it's Blount's, rickets, physiologic, if it's abnormal, whether it's abnormal, and some environmental concerns as well. Blount's disease indications for radiograph, usually you won't take an x-ray unless they're 2 years of age, and then it's non-resolving. You want to have these markers all in place, all 3 of them right now. Non-resolving and asymmetric deformity. That's a good indication the patient has Blount's, and they should have an x-ray. The radiographic features, varus angulation at the epiphyseal-metaphyseal junction, widened interrego-physeal minimally that growth plate. I'll show you an x-ray in a minute. Medially sloped interrego-ossified epiphysis, prominent beaking of the medial metaphysis, cartilage islands, and lateral subluxation of the proximal tibia, that lateral thrust that you see with these kids when they have. There's 3 classifications: infantile, which is less than 4 years of age; juvenile, 4 to 10 years of age; adolescent, which is greater than 10 years. And those 2, juvenile and adolescents, also known as late onset Blount's disease. And it's actually a little bit more prevalent today because of the obesity anomaly going on. This is a Blount's patient from just a clinical evaluation, 2.5-year-old. And then this is your adolescent Blount's 11-year-old boy. Those of us that work in pediatric clinics in major cities have seen this many times, unfortunately. The 23-month-old, you can see the radiographs here. You can actually see this is the metaphyseal diaphyseal angle that's being measured here. It's a line perpendicular to the long axis of the tibia, the diaphysis. 90-degree angle here. This angle goes off the tip of the epiphysis there. And that's the degree right there. It's measured 13 here, 26 here. You can see some of the radiographic irregular formation here, the medial epiphysis, that beaking here. Here's a 12-year-old with adolescent Blount's. That's the growth plate. The epiphysis is disrupted, and that's compared to the normal. You can see there. And then here are the markers and classifications in regards to Age of the patient, tibia vera, Blount's disease, 11 to 20 months, 21 to 30 months in the degrees here. Actually, the degrees are right here, plus or minus and averages right there. This is primarily the Lang-Skoll classifications. The surgeons primarily use this, and use anything over a 3 is indicated for surgery. Secondarily, they'll use it possibly as a bracing, but primarily they use it. Put it out there just so you're familiar with the terminology. Rickets is due to vitamin B deficiency in kiddos, and this is real typical where you see the medial compartment ablated there. And you also see in rickets the femoral bowing is real common with rickets as well. And you can even see some effusion here going on there in the medial places of the question.
I was going to let you finish, but and I'm assuming like for Blount's or anything like that, most of that literature is going to support the earlier we identify it and earlier we treat it, the better the outcomes are. Maybe
Yes,
that 2 years is kind of that cutoff.
Yeah. Well, 2 years is when you really want to start thinking about.
If it's there treated, you get better outcomes than if you wait and watch it.
Yes. Yeah, I'll talk about that in just a bit. The age. Yeah, it's because it's really important. But you can see the rickets there. We know that orthosis designs have been successfully used over the years. There's some controversy regarding the efficacy, meaning that a lot of these kids, you have a school out there, like the chief at Cleveland Clinic that says if they're bowed, he's not touched, we're not treating them. I almost fell over when he told me that. And then you have the others that, you know what, it's kids gonna outgrow it. You know, it's spontaneously gonna correct. We only have so much of a window to deal with these kids. Unfortunately, so and there's some specific markers that you can look at radiographically and clinically to determine whether or not these patients, and with the growth chart as it relates to the age and the normal bowing of the leg that you can use. There's obviously issues with compliance, especially the lock B design. You know, the kids can't bend; they're walking around. You know, the traditional designs that I always use with a double upright lock knee, sometimes single upright lock knee. They're walking around like Frankenstein. New free motion design increases compliance, increased number of positive patient outcomes. These are some of the designs. You know, the traditional Terry Supan, originally in the 80s, Southern Illinois, did a paper on the medial upright. They had good success with this design. This is out of Scottish Rite in Texas, using it for physiological bowing with the strap approximately, centered over the knee, you know, physiological bowing, the center rotations, with Blount's, the center rotations distal to the knee and to the tibia. And this is a more recent, this is, I think it's 2009, Shriners down in Florida, Dr. Rainey, and the group of orthotists down there. This is a design that they make with a lockable knee, a medial flange, here to keep the knee from, or the medial collateral ligament from being overstressed in development and injuring the medial collateral ligament. But you can see the posterior trim line on this KAFO, how it's cut out to let the medial distal section fall away, come medially, and use the strap to pull it medially. And this is another design that's on the market with a hinge posteriorly that uses an elastic strap to create that corrective force with a single medial upright and an articulated ankle that actually elongates as that angle changes as well. The system that we have, I want to share with you today, is the VBAS, or Variant Valve Adjustable Stress Joint System, and I have the knee orthosis up here because this is how it started. We had a practitioner that said, hey, why can't we use this on a Blount's patient? So we tried it, and actually it worked out real well. This is what the pediatric KAFO looks like, and what the VBAS joint system allows it to do is you can actually lengthen this medial upright, and you can see how it changes the attitude of that cuff. You can lengthen the upright, distally here, and it changes the attitude of the distal section. So you can actually change that long axis alignment and create an actual bending moment of the extremity at the leg because of the ability to do that. It has a self-aligning joint. You can see the camber of the joint here. It's kind of a preloaded position. As you change it, that alignment changes with that and allows it to move it freely. So we have a free unlocked knee joint all the time, so the kids can always bend their knees freely and still have the corrective forces. You can address both the tibia vera and valgum angles of the leg, independent or dependent of each other. It eliminates any inconsistencies of the corrective straps. You know, the strap has to be so tight with any of the other devices if it stretches over time or stuff like that. All that changes, so there's a lot of subjectivity in that system where the DS system, once you change the alignment, set it, it's there. All you have to do is don it on the patient, take it off. It's going to be consistently the same. Posterior opening, easy to don and off. It's self-aligning knee joint. You know, from a practitioner standpoint, you like your knee joints to move freely. It's really a pain when they get out of alignment and you start loading things and stressing things, especially that double upright system like this. So it's self-aligning, saves you a lot of time and simplified adjustments. I'll show you the device real quick, sample of it. This is it here, again, free motion. And you can see, we actually made this change here in 2011, I believe. For two reasons. We cut it here for growth, so as the child grows, these condylar affairs stay constant with the anatomy, whereas if you just lengthen the joint, these would stay here, and the joint would move up, and you get the knee center up here, and you wouldn't get the containment control with the proximal tibia. The other reason we did it was the ability to address tibia vera, center rotation here versus here, because before, if you did this, it would just change in a long axis angle. Now when you do this, you can actually see how it changes this attitude here and also addresses it at the knee and indirectly at the femur as well. So we added that adjustability capability of being able to address the tibia vera along with the genivalvum or verum. In this case, it would be verum. That posterior opening, traditionally with the tamarack free ankle joint. And you can see when I have it in this position here, how freely that moves. I can jack this up like an inch and it still moves freely because of the self-aligning capability. You can see the alignment change there versus there. It's significant. And
You sell that knee joint separately?
No, because it's a patented knee joint and it's finicky. It has to be fabricated, the jigs that we have and stuff to be able to do it. At least right now, it's just not practical to do it. And it's important that it's made properly, so it works properly. But anyways, with the tibial adjustment, I'll show you how this works. Typically, when you receive it, there's a little bit of a gap laterally. But you can actually see how that changes. And then shorten that upright, that actually brings that gap together, which actually creates a corrective force and straightens out the tibia. Okay, we've taken it from a bowed position here, right lower extremity right here, where it's gapping here and closed here, so it's in this position, and we straighten it out, take it to this position, so we're straightening it. And you can see how that straightens that out a little bit better, and then we even lengthen it there. And you can see how it's actually bringing in a little bit of valga from the vera. It's loading it.
How much growth are you allowed?
It depends on the size of the kid. You know, we got a picture of one that's only the size of a 16-ounce bottle. So you're only going to have maybe a ½ inch to an inch in that. On average, in this size, probably about 2.5 to 3 inches of growth, which is pretty significant.
Average time-wise growth for a child using the brace?
You can usually get a year to year and a half out of it.
Yeah.
Yeah, maybe 2 years if you're creative and push it. You know, maybe add some extensions to the uprights and stuff. You can see that the femoral section could be lengthened too. And the femoral section is lengthened based on 2 adjustment holes distally, 1 hole proximally. But the whole objective is to keep things balanced. What you don't want to do is just keep pushing the tibia out and not address the femur angle. You want to be able to balance the femur in relationship to the attitude of the tibia. So, you know, it's somewhat subjective and dependent on how much soft tissue the kids have, and you can see how that can change. So we're actually increasing the angle, and you can see the tibial femoral adjustment with this maxed out here and maxed out at the top, the angle there, how much actual valve attitude we've actually increased there in the alignment of it, and also in the actual center rotation of the tibia there. What else, does anybody else notice anything in those particular slides other than the alignment's dramatically different? in the long axis of the limb. Look where the foot's at, over here. So that's a component of Blount's disease is rotation. A lot of these kids are instantly rotated. As you elongate this upright, it creates an external rotation of the lower leg with the adjustment in that, which is kind of a neat thing. So it's a triplanar adjustment. Adjusting rear valgus. AP-wise, you're addressing just the general structure of it. And then also addressing the transverse plane rotation, which is kind of a nifty thing. And that's at an extreme. Sometimes you probably wouldn't even have to go that far, just clinically, whatever's appropriate for that patient. Here's one particular patient that showed radiographic progression at 6 months follow-up. At a 6-month follow-up, the doctor considered a traditional lock knee design. And this isn't a bad way to do an initial assessment. It can even be recommended to the physician just to take a picture of the patient and just draw a line on the limb, or just have a picture so that they can associate it. Next follow-up, they take another picture. The kid's bowed more or is corrected. You don't have to take an X-ray and radiate them. Plus, families relate to this. Orthotic evaluation was at 1 plus 11 years of age. You can see here. The angles that you'll see in the literature, there's 4 different angles that are represented. The tibial-femoral angle, which is through the long axis of the femur, the long axis of the tibia centered on the ankle, centered on the head of the femur here. And those angles are there. The metaphyseal diaphyseal angle is the primary angle that the physicians will look at for Blount's disease. Shows it right and left. Usually anything greater than 11 or some literature says greater than 15 degrees would be considered Blount's. Most of it supports the 11 degrees. And then epiphyseal and metaphyseal angle, that's what Supan group out of Southern Illinois, they use that as their measurement. You see it in some of the literature. And the metaphyseal diaphyseal angle of the femur. That as well, we'll look at that. Alignment standpoint. So this was 4 months later, 2 plus 3 years of age. You can see the alignment and the angles improved, significantly. I think it actually got a little worse on the left. And you can see clinically the presentation, just how much better he looked. And then 2 plus 9 years, and actually was discontinued at this state, how much straighter he looked in the angles. 10 and 6, metaphyseal metaphyseal diaphyseal angle of 0 and 7 degrees. Better there. And then 3 plus 1 is a follow-up. How we get better there in the angles. He's at 0 degrees. Which he actually should be in some problem there. And, the physician decided to take him off DC to orthosis early. I probably would have recommended that they stay in at that point. It's better to keep him in a little longer until they get to these normal angles. And he's not quite there. And the metaphyseal diaphyseal angles are obviously within a normal range. This is another patient. This little guy, this is like a summary I'm doing in the front because it was a patient that was treated with an existing system and then they converted it over to the VVAS system. It originally was fit at 1 plus 7, 1 year, 10 months. A lot of people that aren't familiar with pediatrics are confused by that. That's 1 year, 10 months old. Originally was fit with conventional lock knee double upright design. 17 months he was in the lock knee design. There were some compliance issues and they were discontinued in 2008. 3 months later they were reapplied. At 3 plus 10 years was fit with a VVAS free motion design and then validated wearing compliance leading to the optimal outcome. So this is the initial 1 plus 10 years. And you can see the angles pretty big, significant, big time. And people have challenged the physician's original diagnosis on this being Blount's or not. Technically, this child probably has rickets. His tibia actually presents. He's got the metaphyseal diaphyseal angles that measure that of a Blount's patient. I think the big thing is that we just recognize that the child has abnormal bowing and obviously falls outside of the normal growth and development, and that they should be treated for the device. Here you can see in the lock knee design is actually discontinued here 3 months later. It's placed back in the device here because it got progressively worse in this 3 months between the two. Actually improved but then was followed up again a couple months later and was regressing again because there were compliance issues with the device. Was fit with the VVAS, and you can see 6 months after being in a VVAS of 4+4, the angles reduced significantly. I think the big thing is not only did the angles reduce, but his age of 4+4 years, it's tough to keep some of these kids in braces, and there were some language barriers and stuff. And the orthotistical physician really felt that it was the free motion that did the trick, and the kid being able to move around. And then a 5+1 was followed up here, and it was discontinued. But I don't have a new X-ray on him. Eventually, I'm going to get something on this little pipe. That's just I like to show that because that's a 16-ounce water ball. That was one we made for an achondroplasia patient out of Canada. That it's a dwarf patient that was 2 years old. So it was a little tiny little thing. Any questions on that part of the bottom part? Did I pass that around? Can you pass this around? The screws are out of the distal portion, so you can mess with the alignment of it.
What was the name VVAS?
Verum valgum adjustable stress.
Okay.
This is another study that was done on patient post-operative management using a technique called hemiepiphysedesis, where the surgeon actually goes in and he puts a plate over the growth plate on the healthy side. I'll show you the X-ray in just a second, but it's adolescent tibia vera, so it's the older kids. The initial X-ray was taken in March 2009. The patient was 11 years old. These are the original measurements, and I won't get into the specifics of this due to the time. If you have any questions specific to these, I'll let you know afterwards. But you can see the actual deformity, right over here. That collapsation of the medial tibial condyle area, the varus alignment, tibia vera. You can see how the femur's straight here. Tibia vera there, that's indicative of flounce where you have the bowing in the proximal third of the tibia. This is the actual hemiepiphysedesis. She was vitamin D deficient, initially fit in 2009 with the KAFO, no other previous treatment or history. Had the proximal tibial hemiepiphysedesis and a distal tibial hemiepiphysedesis. A healthy growth plate on the side of the bone was healthy, where it's not collapsed, where it wasn't being stressed, was where the plate is placed over. You can see it here at the ankle and here at the knee. To stunt the growth in that plate, take some of the load off the medial growth plate, allow it to grow. And then this was 2 months post. Whoops, right there you can see not a big difference. Don't really need to take it with a brace on. And here was 10 months post, and I didn't finish up the measurements on that, so we're going down. But you can actually see how the volume's increasing here on the medial part of the alignment's a little bit better. And then this was at 16 months, where you can see the medial proximal tibial angle. That's what they look at in these kids. Was in an acceptable range, and the still had some geniuverum going on there. You can see the volume and the height of that medial tibial condyle area, and much more improved that was. Good response from that. This was just to show the alignment pre and post bracing, the degrees, and just what it did. The original design was made with just a single ankle joint, and there were some concerns. There was a rotary component that the patient had, and usually if they have that, we recommend a medial and lateral ankle joint, just to cancel or help cancel out that rotary component. If you don't have it, it will rotate and actually go into more varus. And this was the result, again, a single medial joint, a single medial joint right here. And this one had the medial and lateral joint. You can see the difference. It was pretty significant. The difference in the control that it offered by just spiking it down on the lateral side along with the medial side down into the foot plate. I want to show that. Orthotic protocol needs to be a family history with abnormal alignment. Lateral thrust. Rainey was big on this. Dr. Rainey, she published most of the literature on the flounce. She was out of Tampa, Shriners in Florida. That was a big component that she looked at. 2 to 3 years of age with radiographic evidence of progression. Juvenile and adolescent for the late onset kids with abnormal angles are pre and post-operatively managed. It's a questionable area. If you look at the literature, a lot of these kids don't get managed, but I think with this free motion system, with the obese kids and stuff like that, I think there's a great opportunity to do that. This slide is actually specific to obesity. some markers to look for when you have greater than 10 degrees of varus angulation that exceeds the forces necessary to facial growth. So basically what that's saying is you have the added weight, you have the deformity that's beyond 10 degrees. It puts so much force, the Fruiter-Bergman principle on the growth plate, that it stunts the actual growth of the growth plate, allows the lateral compartment to grow properly. There's a higher knee adduction moment during early pregnancy, meaning there's a varus moment that's going on. A fat thigh gait where there's just so much soft tissue between the legs that the patients have to actually walk in a bow leg position. And then reduced bone mineral density is associated because of the diets of these kids. They don't have good bone density. And this is a real recent article here that's actually associated increased risk of Blount's disease, BMI, and vitamin D deficiency. Of the two have actually correlated that together. It has to do with diet and things like that. So when you're treating Blount's kids, when you look at it radiographically, you want to typically not take the x-ray until they're 2 years of age. You want to make sure they're non-resolving asymmetric deformity. The markers to consider orthotic treatment, older than 2 years of age. The tibial angle, the tibial femoral angle greater than 15 degrees, the metaphyseal angle greater than 11 degrees, epiphyseal metaphyseal angle greater than 25 to 30 degrees. In summary, significant improvement in compliance successfully used in treatment of a non-traditional patient population. So overweight patient, that second patient was considered obese. And if you look at the literature, it's contraindicated for these patients. So I think having a system, again, that patients are going to comply with better gives us a whole new market that we can go after. Bilateral involvement, again, a lot of cases don't do as well as unilateral involvement. The lower incidence of good results. Greater than 3 years of age at start of treatment is recommended to not treat with children older than 3 years of age. And there's a positive application in regards to using it for juvenile and adolescent. Just from a mechanical standpoint, when you have abnormal alignment, abnormal mechanics happening, if you can counter that stuff, it's a good thing. Complements, this thing just like doing its own thing, I think. Complements post-operative management. We've had several cases that they've actually post-operatively recommended devices just to help stabilize that hemiepiphysedesis patient that I was talking about, because the alignment was abnormal, even though they surgically internally corrected some things. The doctor wanted something externally to counteract that. Growing patient need, patient and practitioner effective, friendly, and should be affordable. From a surgical standpoint, this is the key in the literature, the orthopedic surgical literature. If you look at it, it's very important that the child can be untreated any later than 3 years of age, because the doctors want the patient in the device for at least a year to see what kind of results. The reason why is the research has shown that at 4 years of age, if they wait beyond that, there's a significant decrease in the success of the surgery. So at 4 years of age, it has a 43% recurrence, so there's a success rate of about 57% with these kids if they're going to resolve long term. The Langham skull's got to be greater or equal to 3. Typically, obesity is an indication for patients to be surgically intervened. The overall surgical success rate varies between 50 and 83%, okay, on average in the literature. This is a particular study, and I only pointed it out because it was kind of, out of 12 patients later on in life, 19 limbs. Those patients average 2.5 operations per limb. It's a lot of surgery for kids to go through. 4 operations per patient, a lot like that. So, worst case scenario, if we can get them in a device that corrects the bowing of their limbs, and maybe they have to have maybe 1 surgery or 2 surgeries, we'll help them along. Better yet, have those surgeries. 8 patients actually later in life, regardless of the surgeries, still had DJD in the medial compartment, since they still had an issue with that. And the Langham skull was greater or equal to 4 at the time of treatment of original surgery. Poor outcomes greater than 4 years of age. Look what happens if they wait later than 4 years of age. It goes from 43% to 88%. And that's what the literature shows on this current stuff.
Joe, what are they considering success? Is that getting those angles back within normal, correcting it, maintaining it halfway? I mean, what do they consider success?
Good question.
Well, I guess my question is, are we holding the orthotic success at the same standards, or do we have different standards for?
Getting into the normal alignment, that's their goal, right? And maintaining it, and not having it regress or recur back to, not necessarily the original form, but progressively forms. The challenge is with the orthopedic surgeons and how much there's a philosophy in there to overcorrect. There's a philosophy that you shouldn't overcorrect depending on the surgical methods they use and things like that, because if they overcorrect, and there are some studies that I've read that actually went the other way. They overcorrected, they took the patient in an overcorrected position of valgus, and they went into more valgus. Instead of creating or resolving the problem, they created another problem. So it's a balancing act to determine what angles is most appropriate for the patient. So we have a new design that needs a new approach in regards to the literature, traditional versus the VBAC joint system. Free motion works. That's the primary benefit of the system, creating a bending moment throughout the full range of motion. And the design offers a non-invasive solution for non-resolving lower limb bone deformities, indicated for genu-barren or valve deformities. And we've done several valve deformities. It's pretty complicated. I think it's a great tool. It's really our responsibility as O&P professionals to make people aware about our skill sets, not only specific to this device, but in general, to inform people what our capabilities are, what tools we have available to us, what systems, and there's a lot of new designs and systems that are out on the market. Just as a general comment. Like to acknowledge these people for their efforts in assisting with the study, Bud and Haley and Hanger in Austin, Texas, and Dr. Kahn at Dell Children's Hospital, and Adam Engstrom at Hanger, Board, Ohio, Dr. Handler at Akron Children's Hospital.